Welcome back to our podcast. Today we are going to talk about melasma, all things melasma, how to treat it, when it is, and everything.
Very frustrating
Yeah.
skin condition, melasma.
Yeah.
So what is melasma?
So it's pigment dysregulation that is influenced by hormones, heat, sun, genetics. It's all those things combined together, and it basically shows up as pigment, usually on the cheeks, forehead, upper lips, sometimes even the lateral neck as well. And it's kind of like a muddy brown pigment on the skin.
Mhm. Yeah, I like calling it like dyspigmentation because what that means to me is there's some areas that are darker and there's some areas that are lighter, which is exactly what you see, right? Like some areas there's way too much pigment or brown, and some areas there's way too little. So you get that kind of mottled dyspigmentation. That's really frustrating for patients. And it's also very hard to cover with makeup because of the light and dark areas.
So, how do you approach melasma in a patient, and what treatments are you?
So the first thing I do is I have the patient take off all of their makeup and I look and see if it's actually melasma. I don't know if it's because we practice in Florida where the sun is just so strong, but I would say there's a good percentage of my patients that get referred to me thinking that it's melasma, but really it's just poikiloderma, which is sun damage. A woman of childbearing age with pigment on their skin is not always melasma. Sometimes they had a laser and they're burned from it, so it's hyperpigmentation, but the majority of the time, if it's not melasma, it is just regular old sun damage. So, number one, make sure it's melasma, which I think you kind of have to have an eye for as a dermatologist. What is causing this brown? Like I said, not all brown in women of childbearing age is melasma. So, number one, make your diagnosis of melasma. And you don't need to do a biopsy or anything. Like, just clinically look at them without any makeup on, get a history. Did it get worse with pregnancy or childbirth? Or, if they spend 10 minutes out in the sun, does it pigment? Okay, well, if all of those answers are yes, it's probably melasma. Is it in a good pattern or is it kind of going down just here? And, not up here at all, and they wear a baseball hat wearing tennis every day. That's probably just regular old sun damage. So if it is melasma, I like to offer patients all of the evidence-based treatment options and kind of get to know the patient, what fits into their lifestyle. Obviously, the easiest, kind of quickest, cheapest is going to be a topical. So I like the compounded topicals that we send to a special pharmacy that makes like kind of exactly the recipe that I'd like for the patient. I would say the foundation of any good melasma treatment is going to be a really high quality SPF. So a mineral SPF. And I always counsel patients, look, you can put it on in the morning and that's all well and great. But if you're going out for a walk at noon or you're picking your kids up at 2:30, you need to have some form of reapplication. So is that, you're putting your sunscreen in your bag and reapplying it before you leave the office? Or is that, a mineral brush that we like that you kind of swipe on before you go out? Like what fits into your lifestyle? Find something and use it, because there's no sense in doing topicals or lasers or anything for melasma if you're not going to protect yourself from the sun. Put a hat at your door when you go out walking the dog, wear a wide brim hat, all of these kind of lifestyle changes. But the foundational is going to be sun protection. So sun protection, topicals. I love lasers and I love peels for melasma. And I think kind of the sweet spot of melasma treatment is always going to be a combination of kind of all of those. So lifestyle like sun, a good topical if they can tolerate it, because some people can't tolerate the topicals. And then, peels and laser. And I usually do peels and laser on the same day, but you can't separate them out if patients are having downtime or whatever. If they don't have the downtime, you can separate out peels and lasers. So that would be kind of how I think about melasma. I think, in the recent years, we've come out with some good oral medicines for melasma. I think there's definitely pros and cons to them. So, getting with a dermatologist to talk about whether you're a good candidate for some of the orals, because I do think they have good data. Your oral TXA would be kind of my favorite. So getting with a dermatologist, doing the orals. But other than the orals, I would say, a combination of all the treatments is what I found has worked best for my patients.
Yeah, I agree with that. I mean, what's your kind of go-to as far as like your topicals? What's it that you like?
So I would say hydroquinone, 5 to 12%, a little bit of tretinoin or retinol if they can tolerate it. And then, depending on if they have red, I'll throw in some niacinamide, and then I'll put that in a base of hyaluronic acid or some cream. And there's some, you can do some topical TXA too, topical antioxidants like vitamin C. You can throw that in there too, just kind of depending on how bad it is, whether the patient has a tolerance for a little bit of peeling a couple times a week, really customizing that for the patient, the topical.
Yeah. And then as far as chemical peels, we usually do jasnurous, just something with lactic acid, salicylic acid,
Mhm.
and kind of doing that either pre-laser or in between in the interim, because it's a very nice light treatment, but it does kind of get that superficial pigment up and off,
Mhm.
pretty
For sure.
effectively.
Yeah.
And then, as far as lasers, usually we try and do something like Fraxel. So 1927 is definitely going after just that pigment. We are very cautious with kind of settings. We don't want to overheat the skin, kind of have more tendency towards melasma. So we definitely take a stepwise approach.
Mhm.
If anybody is saying, oh, I can get rid of your melasma in one treatment, don't go to them, because we want to be more cautious with the amount of heat, with the amount of pigment we're picking up, because it's dysregulation. What we don't want to do is then dysregulate it more. So,
Mhm.
you know, 3 to 4 sessions realistically to kind of get 70 to 80% of the pigment. That's a good outcome.
Mhm. For sure. Yeah, and I think I love the laser piece of it because although I think the 1927 has the most data for melasma, I think being able to pull in other lasers when we want to or when the patient needs to, if someone's a little bit older and has some wrinkles, I'll pull in a 1550. I find myself pulling in more and more 532s and vascular lasers with my melasma patients just because sometimes their skin can be a little beat up. And although what they say in the mirror is brown, what I'm seeing is brown and red. So I know if I just treat the brown and I don't treat the red, once I treat the brown, they're going to be back in here asking me for a vascular laser. So I find myself more and more just doing that with the 1927 or whatever laser I'm doing because, if you want to treat the patient holistically, get the best outcome, you need to treat what the patient has. So I find myself pulling in a 532. I also find myself doing a lot more erbium 2940 than I originally did in my practice for the melasma. I think that can clear some of the really deep pigment that even the 1927 can't clear. So it is fun. I like the laser component of treating melasma because you do get to really customize that for the patient. And, it is a challenging case always, just because you're always thinking about cooling. You don't want to overheat. You really have this relationship with those melanocytes that you want to continue in a healthy way. You want to clear the brown without, overdoing it. So I like the kind of challenge of the melasma patients for sure and lasering them.
Yeah. I think the other component is that some people come in and it's melasma, 2 or 3, maybe 4 treatments. They're kind of all well and clear, and then they're really good about sun protection. But we do live in Florida. So I have patients who come to me say, I've tried every topical. It really just doesn't move the needle. And I love being outside on the boat. Like, what do we do?
Mhm.
Then I tell people, okay, so our option is basically we're going to start an oral TXA, and I will use the pigment kind of, lasers to get the brown up and off. And the oral medicine is going to prevent it from kind of getting worse when you do go outside, as well as sun protection, all the things that we talked about. But that's kind of the next step as far as the key component that even with the most cautionary people, we live in Florida, so reflection off pools, off the ocean, off those things, if you like to be outside, that's a really hard, gamble for me to say, okay, you got to stay inside. So the next thing is going to be, okay, so it may be that every, fall, winter, we may still have to do some cleanup, or you can kind of, combine lasers to get pigment up and off, and then hopefully get longer clearance with an oral option like TXA.
You're not telling everyone to just sell their baby.
No, go enjoy your life. And,
Yeah.
if the case may be that, I see you every fall, winter, and we do a couple sessions just to get, perfection, then that's what we have to do. But,
Mhm.
it's not our goal. That's not something we want to do. We want to make sure that everything's, well and good for longevity wise. But just because of certain people's lifestyle and what they have going on in their history, that may be something that we suggest is going on an oral, just to kind of prolong that longevity of that.
Mhm. Yeah, for sure. I completely agree with you.
Cool. All right. Well, thanks for tuning in today. And if you have any questions about melasma, feel free to leave a comment or DM us.